Medical revalidation of Puerto Rico, clinical vignette on mucormycosis, mucorrhizopus in a diabetic patient. Clinical vignette. A 58-year-old man with a history of poorly controlled diabetes mellitus presents to the emergency department with facial swelling, headache, and nasal congestion for the past 5 days. He initially thought he had a sinus infection, but his symptoms have worsened, and he now has facial pain and black nasal discharge. On examination, the patient appears ill and lethargic. He has periorbital swelling, erythema, and black eschar on the nasal mucosa. Neurologic examination reveals cranial nerve involvement, ophthalmoplegia, ptosis, and a decreased level of consciousness. Labs: blood glucose, 450 milligrams per deciliter. Leukocytes, 14,000 millimolar. pH, 78.25, suggesting metabolic acidosis. Question: which of the following is the most likely diagnosis? A. Bacterial sinusitis. B. Aspergillosis. C. Mucormycosis, Rhizopus mucor-spp. D. Orbital cellulitis. Answer: C. Mucormycosis, Rhizopus mucor. Explanation: this patient presents with rhino-orbital cerebral mucormycosis, a life-threatening fungal infection caused by Mucor and Rhizopus species. It primarily affects immunocompromised individuals, especially uncontrolled diabetics, especially with DKA, patients on immunosuppressants or chemotherapy. Key features of mucormycosis: acute, rapidly progressive infection, facial pain, headache, sinus congestion, necrotic black eschar on nasal mucosa, hallmark sign, orbital invasion, proptosis, ophthalmoplegia, vision loss, cranial nerve involvement, cavernous sinus thrombosis risk, metabolic acidosis, often from diabetic ketoacidosis, DKA. Why not the other options? A. Bacterial sinusitis, usually milder, lacks necrosis and cranial nerve involvement. B. Aspergillosis, can be similar but is angioinvasive, affects neutropenic patients, and lacks rapid tissue necrosis. D. Orbital cellulitis, can cause periorbital swelling and pain, but does not cause black necrotic eschars or cranial nerve palsies. Next step in management: medical emergency. Immediate treatment: 1 IV amphotericin B, first-line antifungal. 2. Urgent surgical debridement to remove necrotic tissue. 3. Aggressive glucose control to prevent further spread. 4. Possibly hyperbaric oxygen therapy, adjunctive treatment. Without early intervention, mucormycosis has a high mortality rate, 50%.